Welcome back to the Firehouse Medic Podcast. This will be part 2 on ultrasound with Derek Day of Melville Fire Protection District and Chip Lang of Practical POCUS. If you guys hadn't listened to part 1, make sure you go listen to that as well. Otherwise, sit back, relax, and enjoy part 2 with the guys just chatting up for a little bit longer. Again, any studies that are referenced, we will try to include the link in the show notes below. So if you're interested in that, go check that out. Otherwise, enjoy the episode. Go subscribe to our channel and follow us on social media for updates to future episodes. And if you guys have anything you want to hear about specifically, go ahead and comment and we'll do an episode on it. Thanks.
Well, thanks for watching along part 1. This is part 2. Still talking about POCUS. Still got all the fellows here. And we're going to lead right into basically all the research I did coming into this was ultrasound should be the standard of pre-hospital care, specifically pre-hospital care. And how the main time was not so much in scene time reduction or a lot of it was treatment pathway. Like one, it will change your decision-making on a call. It will change the outcome because what you see on your physical exam is going to tell you it's only going to get you so far. Vital signs only get you so far. If you can look into the body and basically tell, oh yeah, that's the problem. We're going to fix that specifically. It's going to change your destination time, destination choice, but then also especially a lot of these are on trauma patients as well, which is relevant. And the main part was that just already giving the hospital enough data to then change their decision-making as well. So it's not just us, it's everyone.
Yeah, no, because we can lead them down the wrong path as well.
Yeah.
How many
100%.
times does that happen? So if we're saying, Alec, that this is the standard, just like the NAEMSP's position on blood products being the standard of care for pre-hospital, as far as those trauma patients go, why isn't everyone carrying it? Why don't we all have it? Why isn't it in every paramedic program? And those are some of the questions I think we hope to answer. So we're going to look at the experts that we brought in, and if you guys had the ability, we'll get into some of the cost of the stuff, but there is no limit. Say I'm a department. I'm like, man, I really think that this is important that we want to start this POCUS program. Where would it? We're going to use Missouri. Another department in St. Louis County doesn't have it. Where would they start? You guys, what do they need to do? How does this get built up?
Yeah, I can start with this. So, this is something that we actually do as part of Practical POCUS is we help not only do the training, but the integration, implementation pieces of it, because it's awesome. You bought a device, right? Usually you bought it because of a grant or because you had some extra funds laying around and someone's like, I want an ultrasound. You're like, cool. You bought it and then no one has training on it. And then I'm telling you the wrong way first, right? Like no one has training on it.
This is how a lot of it gets done. Yeah.
And so then one dude takes a class or maybe a couple and then they're like, great, but then they don't actually start using it. And what we've seen through our own kind of observations, studies, is that if people aren't using this within the first 30 days of training, they're not going to use it. And we're working back at square one. So like those are, and then they don't have a plan in place, QA/QI, how we're going to do image review. We didn't even talk to the medical directors. So now we're trying to get permission afterwards.
Well, it's just like an IV catheter. We don't got to call them.
Right?
It's non-invasive.
So, but I think the first point, okay, the first thing you have to do is you have to decide why and what are you using it for. And I know that's pretty much what the first part of this podcast was, right? Was the what and why. But the reason why I think it's worth bringing it back up, because that is one of the first things we ask any agency who reaches out to us is, that's awesome. What do you already have? Because they already have like the ultrasound machine. They already have the protocols and stuff like that. Then that already kind of guides me where we're headed. If they say we're working from total scratch, which is most of our conversations, like, okay, where do you see using this most and how do you see rolling this out? If you're a really small department, right, you've got 20, 30 people, you could probably do this agency wide if you have a good group. Culture is a big thing here. Culture is what will make or break most training, right?
We've got a whole podcast dedicated to that.
Exactly. So culture is one piece of that. But if I have where it's, hey, you're talking about 100 plus people, that's a tiered system. yeah, like we're talking about, that's hard to roll out system wide unless we have very limited roles for most people. And as we get higher up, we're using more. So those are the types of things that we just have to understand where we start is what are you going to use it for? We talked about during the break, and I think we kind of mentioned it in the first part anyway, but we talked about in the break about how EFAS and IV, right? The two things that probably are like some of the more studied in the sense of this is where EMS should put it in, and probably the lowest yield in many ways, because IVs are hard. Okay. Ultrasound guided IVs are hard. It's a skill that takes 50 to 100 times of doing it consistently to get to true proficiency. And then to maintain it, you have to do it with regular use. So that's not a great one to use unless you're going to be using it all the time, which there are some agencies that do that, right? Especially in MIH, where they're working with substance use and stuff like that. They're doing it because they're doing it on all these hard sticks. So there are some places where maybe this works, right? A lot of places that use nurses who are also working the ED, they're doing it more in their nursing job in the ED than they are in their pre-hospital setting. So not a great one there. EFAS, super easy to teach. It's one that ACEP and ATLS and all these others hit. But when it comes to, again, if we're talking about like a St. Louis County, one as an example, more urban environment, your response, your destination most of the times for most trauma patients is not going to change, right? You're going to take them to a level 1 or level 2.
Right.
And realistically, your response times are short enough that let's say you get to that scene 5-10 minutes. If they already have a positive EFAS in that time frame, they're probably sick enough you already knew that they were going to be sick, right? Like to actually have a good, those aren't the strongest applications. The rural areas, yes, it absolutely changes care there. But the frequency is also lower. So we usually teach EFAS as part of a bigger approach. When we talk about the rush exam, rapid ultrasound and shock and hypotension, then I'm using it as part of a bigger set of data points. So EFAS and IV are not the ones that I know, like.
But that's what gets talked about.
It gets talked about, right?
Absolutely.
That's all
But
I
it's
knew
not the
before.
biggest ones. I think the 3 or 4 biggest ones we talk about, cardiac, especially for cardiac arrest, because it's such a low threshold, but it has a lot of positive impact with patient care if done correctly, right? And there's a lot of time we spend in classes about how we do it correctly and not so correctly. So that's one. Lung is easy. I think we've talked about just how easy lung is. We're talking about, before we even started the podcast, youngest child teaching stuff like that. I taught my 4-year-old how to recognize that the heart was moving and how to see the lungs move. Okay. Yeah. If I could teach my 4-year-old, I can teach a monkey. I can teach a fire medic. So I started my background there, so don't hate me for it. But anyway, no, I mean, seriously, like you can teach anyone lung ultrasound pretty quickly. And then I think the other one is about fluid tolerance, fluid assessment, fluid tolerance. So that's adding in really just the IVC in the mix. And then we can expand that to rush, right? But those are, I think, the ones when I'm teaching most agencies who are like, we're really interested. What should we do this on? I'm like, these are probably top 3 or 4 to focus on first. But what do you think, Derek?
Oh, yeah, I break it down into 3 big things because same thing. I got an ultrasound probe and I was like, we're going to start IVs, which, by the way, you got to have the right probe to even start IVs. The right probe. Completely different probe.
You had the phased array there, right?
Yeah.
Yeah.
So we carry a phased array specifically. So and it's not it doesn't have a dynamic head like the butterfly. So you can't do IVs with our probe anyways. But regardless,
which is what I'm not trying to do.
Yeah.
Ever pretty much. If they're that sick, I'm putting an IO in.
Yeah, and we'll get into probes. But so whenever I taught what I realized and then what I try to pass on to students, because I do think not to put my educator hat on, but we have to give people the why, right? Every paramedic is taught the 4 types of shock, right? You go to an ACLS class. So big, high yield, rush exam, whether you use EFAST, high map, rush, you know what I mean? Like some modification of that, but putting a patient in a type of shock and how useful that is. It is extremely effective, fast, efficient way to go. Do I have hypovolemic shock? Do I have obstructive shock? Do I have, especially identification of obstructive and cardiac? There's a lot of the nerds that are going to be like, and I loved that you said fluid tolerance, nice, perfect, versus responsiveness. There's going to be a bunch of nerds. It's like, you can't use IVC collapsibility. They look at it completely backwards. If I have a plethoric IVC in a trauma patient, you should be doing some investigation because that means that is not hemorrhage. That is,
Let's explain plethoric real quick.
I was saying greater than
IVC.
3. Greater than 3.
it's thick. Your IVC is thick with 2 C's. How about that one? It's thick
with
with
2
2 C's. Okay,
Cs.
it's big. It's great. It's not moving. It looks like a garden hose going through their chest. That in a trauma patient, that's very concerning, right?
Right.
So shock, putting a person in a bucket of shock, huge for every paramedic that works in EMS. Any person doing 911 response, right? Pulmonary, agree completely. And I think some of the best emerging evidence is on its ability to outperform the physical exam in identification of respiratory pathologies.
Even
CHF,
chest
pneumonia.
X-ray.
Yep. And,
Right?
Yeah, and chest X-ray.
Oh, really?
Yes.
Yeah.
Yes.
So
Couple
let's say you're
studies.
going to be like, oh, well, they could do the chest X-ray and the ED or whatever. That's true. It's going to take time, usually about an average of 30 to 60 minutes, pretty easily to get that one view chest X-ray at the bedside. But also, it's less sensitive. It's not as good about picking up interstitial fluid. It's not as good about picking up pneumonia. It's not as good about picking up pneumothorax. Okay, so. And pleural fusions to go with that. Like
Right.
all those things, all the things that we say the chest X-ray is so good at, right? And I don't need the ultrasound because the chest X-ray is going to show me. The nice thing in the ED where this helps is because it's now someone else's job and responsibility, aka radiology, right? But in the pre-hospital environment, it's still you, bud,
Yep.
and you don't have an X-ray. So
that's
it
a great,
still comes back to you.
Great way. Hey, I'm pushing this off on some. They'll give me the results.
Yep.
I'm
Yeah.
moving on to the next thing.
Yeah.
Where we don't have that luxury.
Yeah. And then the last one is cardiac arrest for a couple different reasons. And again, cardiac arrest is an EMS disease, right? I think that out of all the diseases, we are the most experienced in that realm. And we're always pushing that needle as an entity. But it is better at detecting pulses than your fingers are, as we already alluded to earlier on.
Yeah.
All of us who use ultrasound have had that call where we're like, yeah, we don't feel a pulse. We see PEA. And then, again, we can't even, ultrasound has made it to where we can't even the term cardiac arrest is almost nonsensical at this point, right? Because we associate it with pulselessness only to then realize that pulselessness is not a good corollary for cardiac arrest. And then also identification of VFib. It's even better than your monitor. It is more accurate at identification of fine VFib than the monitor that you're using. Like think about those 3 things though, like differentiating respiratory pathologies, putting people into different shock categories and being able to make decisions about treatment and knowing if someone is dead. That is,
We laugh, but it's so true.
that is
It is.
exactly what we do every day. Like,
So if before we jump to the next part, because I think this is really, really, really important when it comes to cardiac arrest, because this is where there is a lot of buy-in, where there is a lot of application, where, when working with funding and stuff like that, when trying to sell this story to different people, whether it's people up at the state or it's people, admin side, stuff like that, cardiac arrest, like we are literally helping save lives because we're using ultrasound. So I want to hit real quick the 4 kind of main things we use ultrasound for in cardiac arrest, and you've already alluded to 2 of them. But I just want to list them out.
No, that's great. This is great stuff.
I'm gonna write
So
these
so
down.
that way,
Yeah.
anyone who's listening to this or watching this or whatever knows. So the first one is asystole versus fine VFib. It's scary the amount of times that your monitor may actually show you asystole when it's actually fine VFib, and you don't notice that unless you have multiple leads on, which again, a lot of systems don't do natively.
No, you just have the pads on.
Right, you just have the pads, the fast look, and that's it. And it's showing asystole, so you think, well, I'm not going to shock it. The 2 things we know that have the best number needed to treat for neurologically intact survival: high quality CPR, early defibrillation. So if I'm
where's
not,
where's epinephrine in that?
no, don't start me on the paramedic 2
Or
and
an
stuff.
IV. Yeah, tempt an IV, remember?
Yeah.
Let's do an IO.
So you really want to get me off track. So that's one, right? Asystole versus fine VFib. Because when you start using ultrasound, when you think you have asystole, you realize just how often it's fine VFib. And if you catch this early, within the first couple of minutes,
That's the key.
neurologically intact survival is a real possibility here. I've had this happen with patients, again, anecdotally here for a second, but I've had this happen with patients where I'm like, oh, like that actually helped. That helped a lot. Another one is CPR quality. So we think we do good compressions because the machine tells us we're doing good compressions, right? But depending on which study you look at, 50 to up to even 80% of the time, we are not doing CPR in the optimal location, even if we're doing everything exactly the way the monitor, ACLS, everyone has taught us, because the heart doesn't always sit in the exact same spot, right? And instead, we're often pushing over the LVOT, the left ventricular outflow tract, which is going to defeat the whole purpose, right?
Yep.
So again, if you correct chest compression, right, where you're pushing early on because you have feedback from the ultrasound, high quality CPR. That's going to result in neurologically intact survival. It's awesome to see when this happens because all of a sudden you see the end-tidal CO2 improve. You see color actually coming back, stuff like it's fantastic.
Better cleft wave.
Yeah, exactly. Number 3, press versus prim, which is basically what we're talking about is PEA, right? Is it actually PEA or is it pseudo PEA? And by that, I'm talking about the fact that the way we're taught PEA is that we're taught the lights are on and no one's home. By that, it's all electrical, no mechanical. But when you think about the H's and T's, and I know that's going to be really scary for some people who are listening to this podcast, right? When you think about the H's and T's for a second, it doesn't make sense. Most people's hearts are just like, it's tamponade, just going to call it for the day, right? Like that's not what's happening, okay? Your heart is going to try and try and try until it can't, right? That's the difference there. So, press versus prim. Press stands for pulseless with rhythm with echocardiographic standstill. That's our classic PEA. Prim is pulseless with a rhythm with echocardiographic motion. That's the pseudo PEA. And what we find out, as Derek alluded to earlier, is that if we put an ultrasound on their heart, we'd see activity, even though we didn't feel a pulse. Now, what gets really interesting is, hey, they got a little rise in their end-tidal CO2, and that heart looks like it's squeezing well enough that it's not looking great. But I wonder if I put the ultrasound on Doppler over the carotid or femoral artery, oh, look, it's pulsatile. I've got ROSC, right? And they're in this really low flow state, but we're inaccurate with our pulse checks about half the time. Again, really scary numbers. Probably with paramedics it is. Yeah. But I mean,
that's why we got you on here. That's why we got you on here.
Now, the last one is confirming cardiac standstill, which when we teach a lot of agencies who are already using ultrasound, they're like, oh, we already use it for that. I'm like, that's the lowest utility of all of them.
The lowest yield one ends up always, for whatever reason, being the thing that everybody talks about. Like, I don't get it.
But it's easy. Is the heart moving or is it not? Right.
True.
So I mean, but you use that at the end of the code, and that's really more of, I hate to say this, but it's kind of a CYA thing, right? You're just making sure you're not calling someone who's actually alive. And at that point, if that's all you're using it for, you've missed all the real benefit, right? The things that you could have brought back neurologically intact survival, that's not what we're using this for. We're using this to just make sure we're not really calling someone deceased who may actually be alive.
But do you guys see how the pendulum has swung? Because all of us can remember, and even Alec, I think even Alec will realize this. When we used to get clinical save awards, you guys, now I'm talking 20 years ago, if you got a pulse on them,
a pulse back, it was good.
That was a clinical save. If you dropped them off to the ER and they had a pulse, that's a clinical save. No one ever talked to me in paramedic school or even the first 15, let's call it 20 years of my EMS career. No one talked to me about neurologically intact survival. There was no way to track it, and it wasn't on my radar of worrying about what's going to happen to them 2 days, much or less 2 weeks down the road. It's not something I cared about, nor did I think about. Working a cardiac arrest was just running through the motions, and whatever happened, happened. There was never a time when I was like, to where it is now, literally when we roll out of the station, all of us believe we're getting this person back.
Right.
And if we don't, we're upset. Whereas before, you were shocked if you got a pulse back on somebody. You're like, holy crap.
3% survival rate, right?
You're like, we got a pulse back on this pit. And you weren't prepared, and then it made it even worse. But what I'm trying to say is all of this is kind of coming at the same time. I truly believe POCUS has helped push this discussion and this topic. Anyway, not to sidetrack you on it, it's just there is a big change in the way people look at cardiac arrests now and the things that we're measuring, all the data that's available to us. The pendulum has now swung.
Yeah.
Totally.
Well,
sorry to cut you off there.
Even in this HEMS study, I mean, in the CPR patients that they had with the HEMS doctors over in the Netherlands, CPR patients, POCUS led to they would most frequently investigate the ventricular function size in 91% of the patients, presence of cardiac tamponade in 80% of them, and atrial filling in 68.6%. That was they're already in CPR. They're doing CPR, and they can still glean all the information. That's wild.
Yeah. No,
What are we doing?
And let's say you encounter tamponade, which I get people go, well, how often do we see that? And I'm like, well, you don't ever see it because you're not.
Yeah.
You know, it's
Muffled
like,
heart tones?
That is a great point.
You don't know what you're missing, but I do want to use, since we're talking about cardiac arrest, my public service announcement for where EMS in 2026 is right now is for every provider that's doing CPR right now, you have absolutely no idea if you are doing effective chest compressions, if you are not using ultrasound in some fashion. And again, I've already had these arguments, so I'm going to eliminate their arguments for them before they can even ask them.
Can I be the guy that argues with you and tells you, but Chief, I've got in title on them.
Yes, perfect one.
But Chief, I put the pulse ox in the blood pressure cuff and just let it run in the background. Like, how is that? Why is that any different than having ultrasound on?
Yeah. So if you're doing those things, great. And and I get it. Like if you don't have that, the question I do get for the people that care is, well, how the heck can I close that gap? So end-tidal CO2 is great, but it's not perfect, right? What you're seeing on end-tidal CO2 compared to what their arterial carbon dioxide is can be dramatically different and is in fact much more different in cardiac arrest, right? Because we're not perfusing the lungs, so they can't off gas. So, but what I hear is okay, well, I have a CO2 of 30, so I have to know that I'm doing good chest compressions. Not if your patient died of respiratory failure and their carbon dioxide level in their blood is 120. 30 would be potentially inadequate.
You mean
Or I push that sodium bicarb, right?
Yeah.
So you want me to think about
Sodium
H's
bicarbonate.
and T's, though? No one really thinks about that during an arrest, right? It's just a mnemonic that's there.
And I would concede that if you put a pulse oximeter waveform probe on and you see a good waveform with compressions, that's a pretty decent indication that you're doing effective chest compressions, or their heart's beating and you just don't know it, which is also possible.
I'm going to tell you guys in 2026, not as much anymore, but it used to be just 2 years ago. I would show up on a cardiac arrest. There was no blood pressure cuff on. There was no pulse ox on. They're like, well, why do I need that? Just the pads, and that's what we're doing. Why, they're not alive. Why would I need to get those numbers or have those?
They're dead, bro. We're going through the motions.
The other
here.
thing I see, you guys, with the end-tidal CO2 argument is, and I'm not against this, and I don't know what the research or the science is behind it, but the ones that put they're bagging the patient, they have their end-tidal in line with the BVM. Every time they lift that mask off or break the seal or do whatever they do, your numbers are now inaccurate.
Yeah.
You know, that's why some places had switched to, they've got the cannula there or whatever on while they're doing it. Some use it in line. But to me, until you have some kind of advanced airway in place, you know what I mean? And you've switched, not doing 30-2 anymore. I don't really count that initial end-tidal CO2 readings as that accurate at all, unless you're able to keep that seal on the patient.
Absolutely. Like there's a reason that we do blood gases, and it's because we need that. I mean, again, end-tidal CO2 is great. I don't want to crap on it, and it amazes me if I show up on a call that's a pet peeve, right? If we're ventilating a human, I'm like, what is our end-tidal? I want to see that value, but in cardiac arrest, it just doesn't completely close that gap. And to be fair, we've been talking specifically about transthoracic ultrasound, right? When we're talking about point of care, even that can't completely that can't completely close that gap. There is still, because we utilize a lot of carotid and femoral pulsatility.
We do too.
However, if I'm pushing on the wrong spot, I can still cause pulsatility there. So really, the only two viable options that exist at the moment that I'm aware of, and if there's more, great, but is where we do transesophageal echo. So we're putting an ultrasound probe in the esophagus. We're watching the heart through the entire compressive cycle to verify that we're actually compressing, or we're cannulating an arterial line and then watching that tracing and moving our hands until we see a tracing on there. And if you're not doing either one of those things, which I understand and I'm not judging anybody for, but if you're not doing one of those things, the reality is that we cannot with 100% certainty confirm that you're actually compressing the heart. And as Chip already alluded to, as of right now, that might be as many as 50 or 80% of our cardiac arrest patients that were not able to resuscitate simply because of inadequate compressions due to hand placement, which again is nobody's fault because you can't tell unless you have those things. That's my cardiac arrest public service announcement for.
And all of us as providers that care deeply about the outcomes, not just numbers, but we know the amount of lives that are affected when you lose one is catastrophic. But we all understand that there is a loop that we have not been able to close, and it can become frustrating.
Yep.
It really can when you understand that. Okay, so we've talked about utility, you guys, as far as those big things. But how do we get to that point? Like, I understand that those are all things that we could do with the ultrasound, but I mean, how do we get? I know what we did, which definitely isn't perfect by any means, but what would be the next step? We've identified the things we want to do. Hopefully, I'm going to guess you guys are going to say you want a medical director that's fully on board or spearheading that.
Yeah, I was going to say, realistically, the next step is medical director, but also you have to have at least some buy-in because from your agency itself. It doesn't have to be everyone. In fact, almost guarantee it won't be everyone, right? But you need to have some people who are actually going to work jointly to spearhead this, because you're going to find that there's a certain amount of resistance. And it's true, again, for those of us who've been around since 12 leads, right? We're pre-hospital. The obstacles and the hoops that we had to jump through to actually get the hospitals to take us seriously with the 12 lead interpretation, right? that was a fight.
That was a thing.
That was a fight. And now it's not. Ultrasound is becoming the same way. But it's sometimes, depending on where you're located, it could be an absolute struggle. If you're in the middle of nowhere, and let's face it, the places that you're taking these patients to, the docs at that critical access hospital may not be using waveform end-tidal CO2. They may not even know if they have an ultrasound at that hospital, right? That's going to be a hell of a jump for them, right? Because again, it's going to be one of those like, well, these lowly medics, they don't actually know what they're doing here. Versus, even if you're going to an academic center, well, now there's that, well, what do you actually know, right? So you have to have certain buy-in. You have to have a medical director who's willing to support that program, right? Because a lot of times the buy-in that I've noticed, and I mean, I had this happen in my own professional career when it comes to using in the ED and getting the specialist that's going to be who's accepting this patient to buy in. Ophthalmology was the worst for a number of years because they're like, why can't you just do a fundoscopic exam? I'm like, I can tell you why, because I can't dilate and I can't see it well enough, right? So you can either take my ultrasound or I can play around for a couple of minutes while you're on hold and say, I saw something on the fundoscopic exam that I didn't see, if it makes you feel better. But the ultrasound, and it took about 5 years, and there was a smooth transition to where that's what they started doing. In fact, they're starting to use it themselves in a point of care setting. But that's a real struggle, right? So you have to have a medical director who's on board, but you have to have local champions. You have to have people who are willing to spearhead it. And it does not have to be top brass. In fact, a lot of times I say you don't want it to be. You want to have a good training officer who's hopefully involved in this process. Don't get me wrong there. But who actually is going to be using the ultrasound is going to be who needs to help spearhead this. And the reason why I say this is because we've trained a number of different agencies over the years. Like I said, we've trained about 1,000 medics and EMTs in Missouri alone. And the common theme that shows up is that places where we've done sometimes the most training out of anyone else in the state, but they still aren't using it, are places where they say, well, we only have one ultrasound, so we put it on the battalion chief's truck or whatever. But the battalion chiefs don't want to actually use this. I'm not picking on Sean here on purpose. I just realized.
It's perfect.
I put it on that truck and they never use it. But the frontline medics really want to use this, but they can't because the battalion chief doesn't even actually bother putting it in the car to start with, right?
Yeah.
That is a problem. And we see that multiple times. So you have to have buy-in across the board there. Now, some of the ways to do that, you attend a class together, or at least you have, some conversations like what we're having here, but there has to be a certain amount of buy-in to move things forward and to see who's willing to try what, right? Is this one of these where we're going to start with just a couple of tasks, cardiac arrest and lung, because that's all we can get people interested in, versus, hey, we got people who are highly motivated. So we're actually going to spread these courses out over multiple months where we're going to talk about some things in the first class. We get them to work on those skills and we add more in the second class and so on. We do that at some districts because it works really well for them. But you have to figure out how far are we going and what are we doing to help support that program? I know Derek's got his specific examples too. So
yeah, there's a couple different pieces to implementation. Ultrasound's kind of weird because there's two different skills to it. There's the interpretation of pathologies, but then also the skill of just acquiring them.
Right.
And then too, one frustration I know with some of the providers early on that is They see the beautiful videos that they look up on the Google,
or that you show in a training class,
or that I show in a training class, and they're like, and then they put the probe on, and then they look at me and they're like, "You're a snake oil salesman. This is complete bullcrap. What if you lied to me, right?" So there's those skills and stuff that's part of it, but you really need I agree completely with what you said, and I have made this mistake, not intentionally, but was forced to make this mistake. It should be on the frontline ambulances. Like, I get the thought process of like it is a financial cost, but it needs to be on the front of the ambulance. Part of the problem with putting it on like a deputy vehicle or a captain's vehicle or whatever is they're often later to the call. So or a crew member gets on the call, realizes they might need it, but then now they're going to be waiting 10 minutes, potentially.
Which does extend your scene time.
And then they're staring at a hospital that's 10 minutes away, and it's, so those are all reasons it should go on the frontline ambulance. But as far as like making someone competent, there's the classroom sessions where we're showing them pathologies and kind of walking through stuff. And then the thing that was missing in our program that we closed that gap. What I noticed is I would train them on what to look for, and then I would give them the devices and encourage them to scan. And the problem that they ran into was they didn't have any good formal training on when to use it and then how to incorporate that into calls. And so having ultrasound simulation training is, I think, super important. So that was kind of our investment for 26 was incorporating simulation into this to kind of bridge the gap of, okay, they know they have they kind of start thinking about the theory behind ultrasound, and they have an ultrasound in their hands so that when they're running calls that they can actually utilize it. But how do we close that gap of like, how does they incorporate into the flow of the call? When should they be doing it? What should they be doing with this kind of information when they get it, right? And how does that drive our care? But yeah, to get proficient, they're going to have to scan so many people. And I've seen this loop over and over again where people who end up not using it is they won't scan the more benign calls. Mm-hmm. They recognize and acknowledge that on the dying patient they need to do it, but they don't feel confident enough to scan the dying patient, nor are they proficient enough to do it in a timely manner. So they don't ever scan that patient because they don't want to delay care, and they ultimately don't think they're competent to do so. But they can't get competent because they won't scan the people who. Right. That's the constant thing I find myself right now in my everyday job, pushing them to do that, like showing up on the syncope call and being like, this is a perfect patient to scan. They're not actively dying in front of you.
I don't know if you guys should be talking about this because, on social media, this we all look like we're perfect. Like our agency carries ultrasound. Like we got it, dude. We are the progressive place. This is what no one talks about. I can't tell you how many lectures, educational courses, trainings, podcasts, or YouTube video. No one talks about what we're talking about here, Chief. And Chip, the same way. This ultrasound is great, but it's not set it and forget it or throw it on and then you're done. This is, if your service chooses to take this on, it is a big investment. Not talking about cost monetary wise, because the probes are not, in the grand scheme of things, you're talking about $4,000 for a probe. It could be a barrier for some agencies, but for most, that's not the problem. The problem is being a good clinician with it, being able to acquire images and then interpret those images. And like you're saying, all these things have to be thought out. They have to be followed up on, and it's continual. It's not something where you can throw it on there. Technically, the ventilator shouldn't be either, but we see it all the time, you guys. So what I'm trying to get at here is, if you decide that this is valuable, which we know that the research and the data shows that it is, then I think you're saying the next step is the agency, from the medical director to the staff on to the newest person, have to be bought into. This is a continual, ongoing learning process that doesn't ever end. So
I want to dissect both of what you're talking about here, because I think this is naturally the next step, right? So you've figured out what you want to do. You've got the buy-in, right? And then now you have training and device acquisition. So, and I'm going to put those two together because it matters, because some people are going to do device acquisition first because of budget or because of X, Y, or Z factor. And then other people are going to do the training first because they know they're going to buy a device, but they just don't know which device works best for them. One of the great things about our training, just plugging in the practical POCUS here for a second, but we're one of the few who does this. We train on multiple different devices. And the idea here is because we have so many agencies that we're helping that don't know what they want, right? Do they want the small wireless GE vScan Air, which is great, good image quality, it's nice and small, it's wireless, but God help you if you lose it, right? It's, it fits, it's smaller than the palm of your hand. So it's really, really small there. But there's also some delays sometimes with the connection. You have to have relatively newer hardware to go with it. There's the Butterfly Q3. That's the newest version of the Butterfly network systems. It's a wired in probe, so you don't have that same delay. But the image quality is not going to be as good as, say, the GE vScan Air because it uses, without going too far into the technology there, it uses PMUT versus the piezoelectric crystals versus the Echo Iris uses CMUT technology. So, which is, I flipped them, CMUT and PMUT, but they use microchips instead of piezoelectric crystals, but they do about the same thing there, but slightly different image quality, but sometimes easier in acquisition. You're using one device to do all these different things. And then you get these other kind of, I don't want to say more specialized ones, but more of you're going to need multiple transducers. So for example, Philips Lumify, you'll need both a phased and a linear if you want to do everything that we're talking about today at minimum. And they have a curvilinear to throw into the mix with it too. All these devices cost somewhere in the range of $4,000 to $6,000. And there are more of them out there. I'm just naming the four most common we're seeing in EMS right now.
And that's for the probes, Chip. We're not even talking about subscription-based stuff or image storage. There's normally fees and things associated with that
especially for an EMS agency, because if you're a one-off individual, you might be able to do a one-and-done all-in payment and you're good to go. But with more and more EMS agencies, we're seeing even from quotes from those who have the all-in bundle, like Butterfly, who are still charging an annual fee.
Correct.
Because of the fact that you're using 20, 30 plus users. And so they're like, well, this is how you better track the system. And I'm not disagreeing with them on that. It's just adding another layer of complexity. So you're right. So you have some ongoing costs. And the reason why I think this is important to factor in is maybe this is the reason why you go with GE, because they don't do that at all to you, but you may not be able to push those images as easily as you can with Butterfly. Right. Each one has their pros and cons. This is kind of my quick disclaimer to say that with our accreditation, like we don't recommend any specific device. But if you ask the right questions, I can give you the right answers in the sense of like, I can point you to certain things to consider and stuff like that, depending on your agency. But what Derek picks is going to be different than what you all pick versus what another agency is going to pick. So it's important to pick the device that's going to work best in your application. So I think that's one really, really important piece that gets overlooked, and which was why training should happen around the same time, because you need to train on that specific system, but you also need to figure out that the system you're purchasing is the one you want.
To jump off something you said, because you had mentioned like the line staff should be more involved in that decision.
Oh my gosh, yes.
What I've seen time and again, and this actually exists at my current place as well, because each device has its pros and cons. So you will find the admin, right? Part of my job's quality. So
hence the white shirt.
The white shirt. So, one of my questions is going to be, okay, well, we're acquiring these images, but how are we storing them? Where are we putting them? How are we reviewing them and doing quality work? The provider, right? What do they care about? They care about what's the image quality and what's the battery life? How much do I got to charge this and pay attention to it and blah, 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 right? And so
that's a part of daily truck checks because the battery's going to deplete on it or whatever.
And honestly, like, because I picked the ultrasound probes at my old place, and I chose those because I was going to be using them, and I picked the one that I liked because of image quality. And now I'm at an agency where we have 200 providers and 60 CCPs who are scanning tons of people. And now I'm like, and the device that I really like because of its image quality has probably the worst back end. It doesn't have great quality. So now I'm like really struggling there. But I will say my one thing as an educator, and as you're making these decisions, is image quality. If you want your ultrasound program to be successful, that needs to be a pretty top priority, because I could give Chip I almost said the probe name, but I could give Chip a probe that doesn't have good image quality, and he's going to make it look amazing, as would the reps that are trying to sell you these products. But it's not you; it's the novice provider. And the biggest demoralizing thing I see is taking somebody who's excited about ultrasound, who has buy-in, and then you give them a probe that maybe has great other things like background stuff. And I'm talking to the admin people here, who has all the great QA stuff, but doesn't have very good image quality. And then you give it to that person, they scan a couple people, they can't see anything, and then they go, this is a farce. Because anybody that's worked in EMS for a while, we know there's always new and cool stuff, which is why there's trepidation about certain things, because we see the circle of, this is amazing, this is the best thing, it's going to improve the outcome of your patient. And then all of a sudden, 2 years later, they're like, oh my God, it's murdering everybody. Stop doing that. I can't believe you were doing that, right? So you have some people that very rightly so are cautious with this stuff. So that has been the most negative thing for me, which is why when people ask me, I'm always like, image quality first, all the other stuff second. Not that they're not important, because they're very important, and they usually get missed by some people. But definitely that's an education point that I've seen in trying to implement, is that a novice provider is gonna, if you give them a probe that's just showing TV static, they're not gonna use it.
That example literally just happened. He happens to be a friend of mine, but he's one of your newer CCPs. I think this was a week ago or whatever. He just kept texting me. I'm like, what's going on? I was busy doing something, and I start reading his text. This guy is, bought, and he is gung-ho, ready to go, and he is so beat down by 3 patients in a row, he couldn't get much of an image for a parasternal long, and he was demoralized about it. Like, what am I doing wrong? Can you diagnose this over the phone? No, and I think that might be one of the biggest hurdles that we're dealing with.
So let's talk about that, because and just being kind of mindful of time and stuff like that. Training, don't get me wrong, is extremely important, right? But training we can dive into more, and I think we've touched the bits and pieces. You have to take a class. You have to take multiple classes in reality, right? So,
but Chip, where are they getting those from? Outside of, if you live in Missouri, yes, Practical POCUS is a great resource.
Still, we can go anywhere in the country, anywhere in the world.
But do you guys believe that there should be a standardized? I mean, when I started digging into this before we had you guys on here, I thought, well, how come there isn't like a standardized? But then I started thinking about it. There's no standardized vent certification for the country.
I see where you're going. This is where I was headed. We're on the same page. We're on the same page. So this all ties in together. It's about, so we've talked about, just to recap, we've talked about what we're going to do. We've got the buy-in. We have the training device. Okay, so now what do we do next? And it's all about, how are you going to credential this, right? How are you going to say that, yes, the people know how to do this? And I think there are multiple things that have to kind of happen, usually at different stages. One is that you have to actually use the damn thing, right? Which is what we're talking about right now. You have to actually use it. I know, scary, but you have to actually use it all the time. And that can be done different ways. That could be, you practice in the station, you practice on one another, you practice on the different patients, you practice on the dog because no one else wants to talk to you. Because
and there are program simulators you can,
there are simulators
you can buy as well.
Which there are pros and cons to them too. I won't dive in that right now, just in mind of time. But just, if you're going to buy a simulator, be very, very conscientious of what you're buying and how it's going to help. And true with devices too. If you're not sure about a device, get a demo.
Yep.
And don't just have them show it over a Zoom call or something like that. Like, say, I want to borrow this for a week or two or whatever, but don't buy something if they won't let you demo it. That is usually a big red flag, because the manufacturers will let you borrow and let you try it out. So,
we did.
Yeah, exactly. So okay, we've done those things. Now what are we going to do? Well, we're going to practice our exams, right? We're going to use this, but how do we get to a point of credentialing to say, yes, you're ready? And part of that's going to be QA/QI, right? So really, I think it's part of a bigger kind of CQI process is the way I think about it. So continuously, we're going to check your quality and we're going to work on improving it, right? But is there some magic threshold of X number of exams equals competency? Despite what even hospitals will do when it comes to credentialing and privileging, the short answer to this is no. There's not a magic number, okay? Different exams are going to take more time versus other exams. Cardiac is actually really hard to do well, okay? Now, if I'm trying to answer is the heart moving or not, that's a pretty low threshold, okay? I can probably figure that out pretty quickly. But if I want to try and, grossly estimate ejection fraction, that's going to take a little more practice. If I want to try and get into a good apical view, that takes a lot of practice. But the big thing here is that you need a system in place that's going to help do that. Now, what you're talking about, Sean, I think this is a very, very important point is, well, do we need some kind of credentialing agency? My concern is this is going to be another merit badge course. And with merit badge courses, this means money for someone, right?
Absolutely.
And it's not for the agency.
Right.
This is the same threat that comes up in the physician, PA, NP world, CRNA, whatever, all the time, is that we have this discussion of should there be some kind of national certification thing. There's a lot of politics behind this. I'm going to keep this high level, but the answer ultimately that most professional organizations have come up with is no. Right? This is a skill like using a stethoscope or like reading a 12 lead or stuff like that. Or using the vent. I like that one too. Right? Is that it's a skill that needs to be managed at the local level to be done correctly. And because there's not a standard across the board, and I don't think it's a negative thing either, right? But having a process that says, okay, you know how to get this, you know when to use it, you know why to use it, and you can interpret it with consistency there, right? And one of the things that I think, we talk about this when we teach EMS, but I don't think it always hits the same way. And I mean, we do this in the hospital as well. There pretty much is always going to be an adult to your adult, right? And by that, I mean, like, if I don't know what the hell I'm seeing on the screen, guess what? They're still going to the hospital, right?
Absolutely.
So I can just tell them like, hey man, if you can tell me what this is. And I have this happen to me even in the hospital where sometimes someone's going to go to radiology because I see it. I'm about 90% confident I know what it is, but that other 10% is not enough to let me pull a trigger on something, right?
And that's okay.
And that's okay, right? That's okay. That is part of that improvement process. And what I do with that, when the radiologist looks at it, I look and 9 times out of 10, we agree as far as I think this is what I saw and this is what you're saying you saw, right? And the other 10% of the time, I'm learning something new, right? Yeah. So those are the types of things that I want you to take away. You're not going to be right 100% of the time, but a big thing about ultrasound that I realized we kind of glossed over in here. We're answering almost always dichotomous questions. Dichotomous meaning yes, no. Okay. Is there fluid around the heart? Yes or no. Is the heart beating? Yes or no. Right. Those are the types of things. So the quality process here is a lower threshold than with other types of things that we're trying to train. If I teach you a vent, it's not, are you ventilating the patient enough or not? Right.
Yeah.
You popped a few lungs in between, but it's okay. It's okay. Right. Like, no, we got to recognize the fact that there are limitations here. But with ultrasound, a big thing there is having that continuous improvement, right? Having QA, QI in place. And how we do that, I think there's a lot of different ways. I don't want to jump too far ahead in case, Derek, you want to add anything else to what I've said so far.
The only thing to that, just that you kind of set up perfectly is something I see from the naysayers with ultrasound or where people get hung up is it's not always designed to diagnose. It's a specific disease. It's designed to help drive our care. And I think it really shines in that arena versus people get hung up on the evidence on its ability to diagnose, which again, it does a great job with certain things, not as good with others. But that dichotomous yes or no thing, I think that's the way to look at ultrasound and where it really kind of shines. And people often forget that. They get, like I said, hyperfixated on its ability to do X, Y, and Z. Again, tell whether someone's going to respond well to fluids or not.
Right.
It might not be able to do that, but it can certainly answer, should I give this person fluid?
More fluids?
Yeah.
Should I? Yeah, exactly.
What's the minimum time for minimum competency? How much time does it take to go from 0 to
hero?
Yeah, 0 to hero.
I think that's going to depend on the exam type, wouldn't it?
Yeah, it depends on the scan.
It depends on the exam. So I will tell you a study that you're probably not going to find at first glance because you have to kind of dive through the papers a little bit, and I know about it because I helped with it. So PA students, when they were studied and how quickly they could have high interoperator reliability with the radiologist, meaning like they can do it with the same consistency and interpretation rate as what a radiologist is. To do a DVT exam, depending on, takes about 6 to 8 times of doing it. Okay, really, really low
That's
bar.
a very simple scan.
That's
though.
a very simple scan, right? Versus with echo, you're talking about it's probably 50 to 100 times before you're going to get really consistent with what a cardiologist is looking at. And that's like with the dichotomous questions, right? We're not talking about the really fancy stuff.
No,
like,
we're not talking about mitral valve regurg.
Right. I'm not going to do TAPSE or MAPSE or stuff like that off of it because that takes more practice.
We'll talk
and
about that
time.
in part 3.
Yeah.
Right. Part 3.
Well, I think we're going to need a part 3, you guys.
So,
yeah.
but wrapping up with the time that we have here. So I want to tie into this is the QA/QI piece, because I think that's the last thing to really build a program, right?
Yep.
Is that you need that continuing support. How you do that is honestly one of the biggest challenges we run into, because if you're a smaller agency, a lot of times you have a medical director that either doesn't have the time or doesn't have great training themselves to be, okay, I'm going to take this on, right?
100%.
And that happens with the big agencies too,
Yeah.
right? They're doing all the other stuff. They're doing all your other clinical education. They're trying to make sure you're not killing patients. They're trying to help you develop new protocols or guidelines, right? The medical director has a lot to do.
And this is relatively new for even EM boarded physicians.
Yeah.
I mean, this is still a newer.
Yep.
Yeah, it's relatively new, and it's still something that, there's a reason why there are POCUS fellowships for physicians and PAs and MPs, stuff like that, right? It's because this is a bear to take on. So if you don't have that support, it's really hard to build something. Yes, just like you review your PCRs, right, that your medics below you, if you're an officer, you can do that some with the imaging and figure out, okay, is this something that needs to move on? You can kind of help lighten that burden that way. But the big thing we run into is that a lot of places just simply don't have a plan for what are we going to do when people start getting images. Is anyone going to look this over? I would highly suggest so.
We didn't have a plan.
Yeah, and the problem is, if you don't have a medical director that has the time to do it, if you don't really have support staff that has the proper training to do this, which again is not just going to be the same training as everyone else. There are additional pieces you have to factor in. Again, not to plug too hard, but this is something that we offer because we recognize so many agencies, so many hospitals, stuff like that don't have a system in place. So we do image review.
Well, this is made for you to be able to plug.
Oh yeah. Just keep plugging this in, bud. We teach every step of the way. No. But I think realistically, the thing you have to recognize is if you don't have a system in place, you are dooming the system for failure. You have dedicated thousands of dollars, tens of thousands of dollars in many cases on all this other stuff. And because you don't have a program to keep it running, that's where it fails, right? And that's where we see a lot of these fail. Most of the agencies that we have taught, and this is something that we've tried to help encourage the state of Missouri to take on, but unfortunately it just didn't quite work out that way. So we're trying to get other funding sources to maybe kind of keep it going for the agencies that just can't afford it. But that is the main thing we're seeing happen is we're training them. They're excited. They're taking it on. And then they realize they don't have the support systems to keep this running. Right. And that's where things fall apart. And so if you don't have that in place, it's setting you up for failure, and it's going to be a very costly investment. Right. So not going to, because you hit a little bit, Sean, the cost, by the way, for most implementation programs costs less than a monitor.
Absolutely.
Right?
100%.
So that's the whole system, right? We're willing to dish out money for a monitor, no big deal, right? But you want me to buy ultrasound machines? You want me to actually develop a program and stuff and train them?
And there is some investment with that, and they're going to have to, if you want to be successful and not just, I call this the bandwagon thing because I see this all the time. They're like, oh yeah, we got VL. We put it on all of our stuff. Oh yeah, we do RSI. We got this. We got ultrasounds on here. Their programs aren't worth a shit.
Right.
And they're just stuck on some vehicle or whatever it is. They just say they have it. There's a huge difference between a high performing service and a service.
Yes.
All right. And I think that's what we're talking about here. That's the difference in the levels. And I wish we had tons more time to delve into those things. But I think what is important is I want you guys to be able to talk about where anyone that has listened to this, and I hope that those that are listening and are right on the cusp of or wanting to investigate or looking into an ultrasound program, please, no matter what state you're in, reach out to Chip or to Derek. We're going to have their description or their links in the descriptions. But Chip, if you'd give some of that information for Practical POCUS.
Yeah. So practicalpocus.com, POCUS, so as in hocus pocus. Hear that one a lot. Anyway, practicalpocus.com. If you go straight there, you'll see all the different stuff we offer. If you go to courses.practicalpocus.com, which if you hit like the available courses tab or whatever, it'll take you straight to. That's all of our current class listings that you can see. So if you're in Missouri, you happen to be listening to this in the next few months and you want to take a class for free still under the grant, then you got to really hurry up because these spots are filling up. Basically, almost all of our training spots are filled for the rest of the grant. So like if you're not reaching out to us really soon, you need to. We are still having ways that we can help people. And we're working on that right now. We're transitioning with multiple agencies where we're going to help them with getting some of the training free, but they're going to have to pay for some of the stuff that occurs after the end of the grant, but it still saves them thousands of dollars. So it's definitely worth the investment now. So even if we can't get you in a class, we can get you the online content, which will save you tons of money there. And then we can work on the rest from there. And we like to do a train the trainer program, especially for EMS, because it saves a lot. It helps, gets those super users, the champions, whatever, on board. But practicalpocus.com is where you want to go to get started with that. You can also email us directly at like contact us or admin@practicalpocus.com. And that goes to the whole team because sometimes I'm not the best at responding to emails. I get lots of emails every day. So if you respond to the whole team, my wonderful staff reminds me that I need to answer you. So anyway, there's that piece.
No, that's awesome, Chip. And then, Derek, how can they get in touch with you if they want more on like the fundamentals of critical care classes, just general follow-up information, the stuff you guys are doing at Melville?
Yeah, for sure. If you're wanting to sign up for the critical care program, which we'll have our next one starting in August.
Hosted by who? Who's hosting that?
I think Monarch.
Is it Monarch Fire District?
Yeah, Monarch Fire District's hosting that
that's
one.
cool.
They can go to melvillefire.com and there'll be education opportunities. They can click there and do that. If they want to reach out to me, are you guys going to share like contact info?
Yep.
Yeah.
Okay. Yep. Feel free to email me. I am not as fancy, so I haven't got a
I can get you
staff.
set up.
I definitely need it because I get reminded constantly that I need a secretary because I have too many things going on. But they can reach out to me if they have any questions about implementation of ultrasound or any of the barriers. Like I said, I've done it for rural and urban systems. I've made every mistake that you can make pretty much with implementation.
Yep. Why reinvent the wheel?
From start to finish. So I'm happy to share my mistakes with everybody so they can not make them and have a smoother implementation process. So.
Man, I can tell you guys, man, if I would have just had this or been able to find a podcast that had this information on when I first started looking, because these are the two guys, 3 years ago in that journey that I had to lean on. And now to see all the champions we have in our department and how everything is growing, it's just amazing. And I can't thank you guys enough for coming on here. And we've got a lot more content coming. I think we're going to have to bring them both back on to finish up some other things that we need and get Devin in here. You know what I mean? He's our really deep thinker question guy.
Ooh, I like that.
Yeah. So anyway, that wraps it up for this one, you guys, and we'll see you on the next episode.
Yep. Thank you.
Thank you.